Also, you've improved the canister, you've straightened them out, you've improved the canister, you've treated the syndrome, whether it was their shoulder or their hip. You've tried to improve the position of the spherical joint, especially the one that was aberrant. Now you need to know if this stability propagates to the extremities, because that is how you're going to use it. The canister as a stabilization center is not that useful unless its abilities to stabilize extend beyond its borders into the extremities and the neck and head, because that is how you get around by propagating the stability alternatively or altogether through the extremities. So the tests are a natural continuation of testing how well the stability is extended outside the canister, and therefore it has to be tested. It's not, the end is not that the canister is stable. That's just the beginning. Right. And so yeah, that's just the beginning.
Well, yes. I mean, that it's just the beginning. That's always what we end up finding. It's well, you can't just you can't just give somebody a DNS exercise. You have to first do this stuff to even give them the capacity to generate intra-abdominal pressure. Then it's okay, they've got the capacity. You train them how to do the intra-abdominal pressure and basic sagittal stability. So you work on that a bit. You get that. Okay, well, that's not the end. That's just the beginning. We're going to now have to teach you how to upright and teach you how to walk and teach you how to move. And okay, well, that's not the end either. That's just the beginning. We have to test how well these chains function in real life in a variety of positions. And even then, that's kind of just the beginning. I mean, it's still, you still have to continue training. Yes. Yeah, it just goes on and on.
It goes on because we
have a rational way to think about it.
We do, because you must go from fundamental movements to synergies and synergies to ADLs. You can rapidly go through them. You can go through them slowly. It will depend on your on what the patient is capable of, what the goal is for the patient, and what systems you have found are dysfunctional, because different systems may take different may have different schedules in terms of getting them back online. So some things will go very quickly, some other things may take some time. And that is why really we must be very aware not only of the overall model, but also the components. One of the things I'm finding very interesting and which is helping me is something that I think is looking at the canister from the fact that the developmental sequence rarely starts in a kind of craniocaudal fashion. Yes. So the canister in supine, of course, has both arms and legs working, yes. But in prone, it really kind of starts off with the arms. It's the elbows that the upper extremity that first provide the anti-gravity function. And in some patients, it's a good place to start, because that is the sequence. It helps to bring the thorax into the abdominal wall, rather than the other way around, where you are having the abdominal wall activated and you're trying to get the patient to understand that the thorax has to belong, has to join in. And the patient is often may find great difficulty in integrating the thorax into the abdominal wall. And sometimes it is easier to start by using the upper extremities to facilitate the bracing function. And that helps you integrate the serratus anterior, the serape of the shoulder girdle, the rib cage, straight into the abdominals instead of trying to add it later. And the patient is having great difficulty in understanding that the arms are also involved and require this stabilization of the canister. They are not independent add-ons. That
is interesting. That's an interesting point that, we've said it, we said it earlier, that essentially sagittal stability should be kind of established by 3 months old.
Mm-hmm.
And in supine, the support points are all proximal, basically, in the trunk. Whereas the support points in the prone 3-month position are distal.
More
distal. Have the points in the elbow.
That's right.
That's a significant difference. And that's also why you said it. It's when you're lying in supine attempting to do this initially, it can be difficult because you don't exactly know what to feel or what to do. You have nothing to push against almost. While theoretically you do. You're supposed to push off of the supports, but because they're so, in the scapular spine, in the LS or TL junction, that's difficult to feel. Whereas it's not so difficult to feel your elbow into the ground.
That's right.
For 3 months.
It isn't. Yeah.
That's interesting.
Yeah.
That's interesting.
So I have tried to utilize that, and I think it was also I think Susan we had a lively conversation, and she explained this from her point of view, and it really resonated with me in thinking deeper about this function. And so I actually want to thank her for her ideas.
One of the primary DNS prog instructors.
Yes,
Susanna.
she is quite something. I like her ideas, and it just confirmed some suspicions that I was already having, especially with the more difficult patients, and gave me food for thought. So that was great.
If you enjoyed this conversation and want to hear more like it, then please like this video and subscribe to our channel. You can also stay up to date on our latest seminars on our social media pages on Instagram and Facebook @IMTR Seminars.